So today about ITP. So ITP, it is also called as Idiopathic Thrombocytopenic Purpura. So ITP, it's also called as Idiopathic Thrombocytopenic Purpura. This is an acquired disorder. So ITP is an acquired disorder. So what happens in ITP is there is a immune mediated destruction of the platelets. ITP, there is a immune mediated destruction of the platelets, and there is also inhibition of the platelet release from the megakaryocyte. ITP, it is also called as idiopathic thrombocytopenic purpura. This is an acquired disorder. So in this acquired disorder, there is a immune mediated destruction of the platelets, and possibly there is also inhibition of the platelet release from the megakaryocyte. In children, it is an acute disease, and in children, this most commonly follows an infection, and this has got a self-limited course. So if we take children, so in children it is an acute disease and it usually follows an infection, and this has got a self-limited course. If we take adults, in adults it is a chronic disease, but in few adults spontaneous remission occurs, usually within months of the diagnosis. In children it is an acute disease, it follows an infection, and this has got a self-limited course. If we take adults, it is a chronic disease in adults, and spontaneous remission occurs usually within months of the diagnosis. ITP is termed secondary. So when do we call that a patient has got a secondary ITP? So when this ITP, if it is associated with an underlying disorder. So what underlying disorders can cause the secondary ITP? So this could be autoimmune disorders, particularly SLE. In SLE, patient will have this ITP, which is secondary to the SLE, and infections. So if we have this infection, so if we take this infections, HIV and hepatitis C, so they also cause this ITP. So these are the secondary causes of ITP. What are the secondary causes of ITP? So it could be a SLE, or it could be infections such as HIV and hepatitis C. And if we take ITP, the association of ITP with Helicobacter pylori, it is unclear. So is there any association of ITP with H. pylori? It is unclear. And so what happens? How is this characterized by? So this ITP, it is characterized by mucocutaneous bleeding. ITP, what will be there? There will be mucocutaneous bleeding, and patient will have a low platelet count. With an otherwise normal peripheral blood cells and smear. What will patient have? Patient will have a low platelet count, and this is characterized by, ITP is characterized by mucocutaneous bleeding. So patients, how does a patient present with? Patient will be having ecchymosis and petechiae, or patient will be having thrombocytopenia. So this thrombocytopenia can be instantly found on a routine complete blood picture. So what is the presentation of the patients of ITP? They'll be having ecchymosis and petechiae, or patient will have thrombocytopenia. For some, if we would have done a complete blood picture, then patient would have a asymptomatic thrombocytopenia. And mucocutaneous bleeding such as oral mucosa, gastrointestinal, or heavy menstrual bleeding may be present. So if we take ITP patients, patient can present with, a patient has got heavy menstrual bleeding, or patient will be having a gastrointestinal bleeding, or patient will be having a bleeding from the oral mucosa. Rarely what will happen is life-threatening CNS bleeding can also occur in patients with ITP. So patient could present either with the oral mucosal bleed, or patient will be having a gastrointestinal bleed, or there could be a heavy menstrual bleeding, and rarely life-threatening bleed can occur in the central nervous system. Supposing if a patient has got a wet purpura. Okay, so what is this wet purpura? So patient having a blood blisters in the mouth, or patient having retinal hemorrhages. So this will herald a life-threatening bleeding. What are the two conditions which might herald a life-threatening bleeding? So it could be a wet purpura, blood blisters in the mouth, or it could be retinal hemorrhages. So this will herald life-threatening bleeding. So what is the laboratory testing for ITP? So laboratory testing for ITP, we see antibodies are formed against the platelets, no? But laboratory testing for antibodies, it is usually not helpful because of the low sensitivity and specificity of the current test. So that is why we can't measure the antibodies. So when do we have to do a bone marrow examination? So this is done for patients who have other signs or laboratory abnormalities which are not explained by ITP, or in patients who do not respond to initial therapy. We have given treatment but patient is not responding, or patient could have other signs, or patient could have other laboratory abnormalities which are not explained by ITP, then we can go ahead with the bone marrow examination. So if we do a peripheral blood smear in a patient with ITP, so there will be large platelets, but otherwise normal morphology. Morphology of the platelets will be normal, but the size may be large. And if depending on the bleeding history, iron deficiency anemia may be present. So gastrointestinal bleeding, or there could be a menorrhagia. So depending on the bleeding history, what can be there? Iron deficiency anemia can be there when we do a laboratory testing. Apart from this laboratory testing, so in peripheral smear, large platelets are seen. So bone marrow, when bone marrow examination indications are also have been mentioned. And laboratory testing, so this is also performed to evaluate for the secondary causes of ATP. Supposing SLE patient, if we have if that patient has got other symptoms like rash, photosensitivity, or some other thing, so then we have to evaluate for other secondary causes of ITP, and we also have to test for HIV infection and hepatitis C, and then serological testing for SLE in the form of ANA, or if we have to rule out the other disorders, we have to do a serum protein electrophoresis, immunoglobulin levels to detect any hypogamma-globulinemia, and we can also do a selective testing for IgA deficiency or monoclonal gammopathies, and even testing for H. pylori infection should also be considered depending on the clinical circumstance. So what are the other tests that we can order? We can order for HIV, hepatitis C, SLE, serum protein electrophoresis or immunoglobulin levels to detect hypogamma-globulinemia or selective IgA deficiency, and depending on the clinical situation, even testing for H. pylori infection is also considered. If anemia is present, direct anti-globulin testing, okay, Coombs test, it should be performed to rule out combined autoimmune hemolytic anemia with ITP, Evans syndrome. So patient is having both thrombocytopenia, patient is also having anemia. So in these patients, what should be done? A Coombs test should be done. So this test is done to rule out if patient has got both combined autoimmune hemolytic anemia with ITP. So this is called as Evans syndrome. Then coming to the treatment of ITP. So in the treatment of ITP, it uses drugs. So what are the drugs that should be used in the treatment of ITP? So these drugs, they should decrease the reticuloendothelial uptake of the antibody bound platelet. So platelet will be there, antibodies coming and attacking this platelet, and this will be going into the reticuloendothelial system for destruction. So we have to use drugs that decrease the reticuloendothelial uptake of the antibody platelet, decrease antibody production, and or increase platelet production. So if platelets are decreasing, no, so what we have to do, we have to give some drugs which will increase the platelet production, or we have to decrease this antibody production. And if the diagnosis of ITP, it does not necessarily mean that treatment must be instituted. Supposing patient is having ITP but platelet count is 30,000. So this does not mean that treatment should be initiated in all these patients. So though this patient has got 30,000, so there may not be symptoms related to this low platelet count. Patients with platelet counts greater than 30,000 per microliter. So patients who are having the platelet counts greater than 30,000 per microliter, they appear not to have increased mortality related to the thrombocytopenia. And initial treatment in patients without significant bleeding symptoms, severe thrombocytopenia or signs of impending bleeding can be instituted as an outpatient using single agents. So patient is having thrombocytopenia, but patient is not having any significant bleeding symptoms, or patient is not having severe thrombocytopenia, or there are no signs of impending bleeding. So in these patients, what can be instituted? So these patients can be instituted as an outpatient. So if there are no serious signs, so what can be done? Patients can be treated as an outpatient basis. So this is, we have to give steroids. So how much steroids we have to give? At 1 milligram per kg, or we can give a 4-day course of dexamethasone 40 mg per day. So if you're starting with steroids, patients are not having any bleeding symptoms, then we can directly start as an outpatient treatment. So what drugs has to be given? So it should be prednisone at 1 mg per kg, or it should be a 4-day course of dexamethasone 40 mg per day. Although raw immunoglobulin therapy at 50 to 75 microgram per kg, it is also being used in this setting. Raw immunoglobulin must be used only in Rh positive patients. So if you are using this raw immunoglobulin therapy, so this should be used only in Rh positive patients, because the mechanism of action is production of limited hemolysis with antibody coated cells saturating the Fc receptors and inhibiting the Fc receptor function. So raw immunoglobulin, what dose it is used? 50 to 75 microgram per kg. Raw immunoglobulin, it should be used only in Rh positive patients, because the mechanism of action is production of the limited hemolysis. Why this production of limited hemolysis? Because of the antibody coated cells, they are saturating the Fc receptors and they are inhibiting the Fc receptor function. And so we have given this raw immunoglobulin, and monitoring of patients for 8 hours after infusion, it is advised by the FDA because of the rare complication of severe intravascular hemolysis. Because after giving this therapy, there is a possibility of rare or severe intravascular hemolysis. So we have to monitor for 8 hours after infusion. Intravenous gamma globulin, which is pooled. See, gamma globulin means pooled primarily IgG antibodies. They also block the Fc receptor system. Like raw immunoglobulin, this intravenous gamma globulins, which are primarily IgG antibodies, they also block the Fc receptor system, but appears to work primarily through the different mechanism. If we take this IV IgG, this has got more efficacy than anti-Rho in post-splenectomized patients. So if we compare this IV IgG and if we compare this anti-Rho immunoglobulin in post-splenectomized patients, so which has got more efficacy? IV IgG has got more efficacy. So what is the dose of this IV IgG? It is 1 to 2 gram per kg in total. So this is given over 1 to 5 days. dose of IV IgG 1 to 2 gram per kg per total. So it is given over 1 to 5 days. So what are the side effects of this IV IgG intravenous gamma globulin? The side effects of this are usually related to the volume of infusion and infrequently include aseptic meningitis and renal failure. So what are the other side effects of this intravenous gamma globulin? So the side effects are usually related to the volume of infusion, and the side effects infrequently include aseptic meningitis and also renal failure. All immunoglobulin preparations are derived from the human plasma and undergo treatment for viral inactivation. So if we take this immunoglobulin preparations, so from where are these immunoglobulin preparations? They are derived from the human plasma and they undergo treatment for the viral inactivation. For patients with severe ITP and or symptoms of bleeding, hospital admission is required. So patients who are not having any symptoms of bleeding, outpatient we can give this steroids or immunoglobulins. But patients with severe ITP and or symptoms of bleeding, hospital admission is required and combined modality therapy is given using. So we are giving a combined modality therapy in patients who are having bleeding. So this can be done using either high dose glucocorticoids with IV immunoglobulin or anti-Ro therapy, and as needed additional immunosuppressive agents. So in patients with severe ITP and patients who are having symptoms of bleeding, so we are giving a combination of therapy, steroids along with immunoglobulins. And in addition, they might also require additional immunosuppressive therapies. So if we take this rituximab, it is a anti-CD20 B cell antibody. So this has shown efficacy in the treatment of the refractory ITP, although long-lasting remission only occurs in approximately 30% of the patients. So if we take this rituximab, so what is this rituximab? It is a anti-CD20 B cell antibody. So in refractory ITP, so this rituximab has shown efficacy in the treatment of refractory ITP. So in refractory ITP, though we give rituximab, long-lasting remission occurs, that is prolonged remission occurs only in approximately 30% of the patients. And then if we take the TPO receptor agonist, that is thrombopoietin receptor agonist, that is we have to increase the platelet count. So these TPO receptor agonists, they are administered subcutaneously. So which is a TPO receptor agonist which is administered subcutaneously? It is romiplastim. Okay, the TPO receptor which is administered subcutaneously is romiplastim, and the other TPO receptor which is administered orally is L-Thrombopac. So these are affecting in raising the platelet counts in patients with ITP, and these are recommended for patients who relapse or who are unresponsive to at least one other therapy. TPO receptor agonist, examples of TPO receptor agonist are romiplastim. So this romiplastim, it is administered subcutaneously and we have a oral preparation. So what is the oral preparation? It is L-Thrombopac. So these are effective in rising the platelet counts in patients with ITP, and these drugs, no, they are recommended for patients. So which patients we are recommending these drugs? Patients who are relapsing or patients who are unresponsive to at least one other therapy. If patients are unresponsive or patients are relapsing, then we are using this TPO receptor agonist. And other immunosuppressive drugs have also been tested, and the combination of glucocorticoids with mycophenolate. So if we take this glucocorticoids along with mycophenolate, so this appears to be more effective than glucocorticoids alone. So either glucocorticoids or combination of glucocorticoids with mycophenolate. So how much is this mycophenolate given? 500 mg BD. So this appears to be more effective. So which is more effective? Glucocorticoids along with mycophenolate. So this appears more effective than glucocorticoids alone. And splenectomy. So this also been used for the treatment of the patients. We are giving glucocorticoids, we have tapered the glucocorticoids, but in spite of giving glucocorticoids or other immunosuppressive drugs, we have tapered, but still what is happening? Again, there is a relapse of this ITP. So in those patients, what can be considered? Splenectomy can be considered. However, with the recognition that ITP will resolve spontaneously in some adult patients, observation, if the platelet count is high enough, or intermittent treatment with anti-Ro or IV IgG, or initiation of treatment with a TPO receptor agonist, may be a reasonable approach to see if the ITP will resolve prior to splenectomy or other therapies. See, in adults, no, in few patients there is a chance for remission. So in those patients, if the platelet count is high enough, supposing if it is 50,000, he is not having any symptoms. So in those patients, instead of going for splenectomy, so what can be done? We can give this intermittent treatment, okay, because there is no emergency. But sometimes when the patient platelet counts fall, so then what we can do? We can start a treatment, intermittent treatment can be given instead of directly removing the spleen. So this intermittent treatment can be given either with anti-Ro or IV IgG, or we can initiate treatment with TPO receptor agonist to see if the ITP will resolve prior to splenectomy or other therapies. So before giving other therapies, or before removing the spleen, these therapies can be tried. And vaccination against encapsulated organisms, especially pneumococcus, but also meningococcus and Haemophilus influenza, depending on the patient age and potential exposure, is recommended before splenectomy. So before splenectomy, we have to vaccinate the patient. So we have to vaccinate against the encapsulated organisms. So what are these encapsulated organisms? Pneumococcus, but also meningococcus and Haemophilus influenza. So vaccination have to be done against these organisms. So this depends on the patient age and potential exposure. And accessory spleens, so these are a very rare cause of relapse. And inherited thrombocytopenia, okay, so this is different. Okay, so that is about the ITP. And thank you.